Welcome back. I'm very excited about this next talk, as we often hear that over time, people with Parkinson's no longer feel like others relate to them as who they are and start to see them only as their disease. And in some cases, the care partner no longer feels like the spouse or the child, and the roles and relationships get lost. This is where Aaron comes in, as he helps you navigate through the changes and how to rebuild relationships and intimacy. Though much of it involves the dynamics between couples, there are many concepts and ideas that apply to relationships in general. If you are the person with Parkinson's watching and any of this makes you feel uncomfortable, please take this time to stretch your legs, get a snack, or look through the exhibit hall. And so without further ado, I would now like to introduce my Parkinson's Foundation Center of Excellence mentor, Aaron Daly. Aaron is the center coordinator of the UCSF Parkinson's Disease Clinic and Research Center, a Parkinson's Foundation Center of Excellence. He has a master's degree in psychology and has worked in medical and mental health fields for the past 18 years and exclusively with movement disorders for the past 7. He also manages clinical research studies looking at slowing Parkinson's disease progression and exploring new therapeutics such as gene therapy. Aaron is the primary UCSF speaker for PD Outreach Program talks and has presented on a wide range of topics. He is the past recipient of 2 PF community grants to bolster Parkinson's community education and is committed to increasing the reach of outreach and education in underrepresented and minority populations. So please welcome Aaron Daly. Aaron, thank you for being with us today.
Hello, everyone. Thank you so much for joining us today. I hope you've been enjoying the program so far. My name is Aaron Daly. I am the center coordinator for the UCSF Parkinson Center. And I've been asked to talk today about Parkinson's disease, relationship challenges, and how to rebuild intimacy. I'd like to take a moment to thank Ellen Walter for inviting me to be a part of this program. I also would like to recognize Hannah George, one of my colleagues who helped me in putting together this program. And I'd also like to take a moment to acknowledge the Parkinson's Foundation, of which we are a center of excellence. The Parkinson's Foundation puts out a series of community grants each year. And a few years ago, we had the opportunity to put together a program and a series of presentations related to some of the issues we're going to talk about today. And I just wanted to take a moment to thank you so much for the Parkinson's Foundation. Okay, well, let's get started. I'd like to start this off with a quote from Michael J. Fox. So what I say about Tracy is this: Tracy's big challenge is not having a Parkinson's patient for a husband, it's having me for a husband, and I happen to be a Parkinson's patient. I think this is really great at highlighting a couple of issues that can come about with Parkinson's disease and relationships in particular. So I think the important thing to acknowledge is that this is a person who has been diagnosed with Parkinson's disease. And I think too often the disease can sometimes shadow all the things about the person that we recognize, all the things about the person that make them who they are. And I think that it's really important to remember, especially when you are trying to maybe navigate a difficult part of a relationship, that you really need to speak to the person and not necessarily let the disease be the primary focus of every conversation. So in 2016, there was a study that interviewed people with Parkinson's as well as their partners to find out what were some of the things that they were dealing with as a result of the disease, and that there were 6 areas of relationship issues that were identified. One, the overall closeness. So in general, only a really small amount of people reported that there was any sort of feeling of a decrease in closeness. What they did see, though, was that shifting roles, and we're going to talk about that in just a second, but that, that sometimes care partners or spouses had to take on identities, had to take on challenges, had to take on new things that they were not used to, and that created some friction between the two. Sexual intimacy, really, that tended to vary depending on the age of the people that were spoken to. Financial stretch, which is not a surprise, was actually the biggest source of stress for many people. And we're going to discuss just a few things related to that as well. But it's important to acknowledge that financial stress, I think, is something that really is somewhat universal, especially when you're talking about a chronic illness, but that can really create a lot of friction between two people in a relationship. And it's important to make sure to limit as much as you can with that. Engaging in fewer leisure and social activities together. So people saw that they were not doing the same level of things that they were doing. as well as the uncertainty of their relationships. So again, we'll speak about this in just a moment, but that people with Parkinson's sometimes felt that there was a fear of resentment, a fear that they were having to take on this sort of role of being a burden. And that really can create some issues. So the four things that I'd like to talk about today as regards to relationship and intimacy challenges are some of the new dynamics that can come about in a relationship when somebody is diagnosed with Parkinson's, some of the communication challenges. And I'm going to highlight communication over and over because it really is the key to moving into a healthy direction for rebuilding intimacy, rebuilding relationships. The emotional changes that can come about, as well as building, as I said, and rebuilding intimacy. So first off, the changes in the relationship dynamic. So one of the issues, as I spoke about before, is that there's a new dynamic that challenges maybe some of the pre-Parkinson's identities. And so there is the care receiver and there is the care partner. And the main issue that can come about is that there might start to be a shift towards a more parental than spousal role between two people. And the problem with this, obviously, is that one can challenge maybe some of the perceptions of a marriage or a union between two people, and also just the feelings of dependency with regards to the person with Parkinson's. No one wants to feel like they are a burden to another person, and certainly not the person who they love, who they have chosen to spend their life with. Another issue that can come about is this sort of idea of the breadwinner identity. So that it's possible that the person with Parkinson's may not work anymore, but the caregiver may continue to work, and there might be a shift to sort of the primary breadwinner in the family. And this can shift the identities, that can shift sort of how people see their roles in the relationship. They might be asked to take on additional things. So say a spouse has never been the person to do the taxes, but then for a variety of reasons, maybe that's something that they have to take on, and it's not something that they are necessarily comfortable with. So it's important to remember just to be able to accept those sorts of things, but also accept that it may be a challenge. There may be a period of shift, that occurs between someone who has never done something before and then starting to feel comfortable in that role again. There might be protective instincts also that come about, that may actually increase the closeness between two people. And again, just acknowledging that, there can be some issues related to that feeling of dependency. So I'd like to acknowledge this is something that I will speak about throughout this presentation. I was gifted a series of journals by a person in the community several years ago. That was written by this person's mother, and it was a document of her father's Parkinson's disease for 7 years. Her father had been a scientist, and he was diagnosed in 1986, and he had asked his wife to keep a daily journal chronicling his illness and the day-to-day changes that she observed, that he observed, as a way of sort of memorializing and also cataloging maybe the symptoms. He was a scientist and he wanted to contribute in some way to the general information related to Parkinson's disease. So this person, which we will call John Doe, was on 6 tablets a day of carbidopa-levodopa. His primary issues were tremors. He had bradykinesia and rigidity, so the slowness and stiffness. He had chronic constipation as well as urinary frequency, which is an ongoing issue. It's something that probably a lot of people with Parkinson's disease can relate to, and also did tend to have some balance issues, which we're going to get into. So Jane Doe, his wife, was also a mother of 4. The children were all grown and out of the house by the time that this had happened. And as I said, she cataloged 6 years of day to day. So the first quote that really struck me when reading these were things related to the communication and the problems with communication that they started to notice and that Jane started to document. Then he wanted to talk and got me into tears. So he's scared of his future. So he's afraid of falling. So he's frustrated. Aren't these common to all people? I guess I expect him to hold up his end as best he can for as long as he can and relinquish what he must as it becomes necessary. Grace under pressure. What I don't understand is what he expects from me. I have to be 2 people, the subservient, obedient wife and the competent, organized adult at the same time. And sometimes he doesn't particularly like either one of me. So I think this is really important because it shows a number of things that are coming up that we're going to see possibly in relationship problems between a person with Parkinson's and a primary caregiver or a spouse. And we've talked about already this shifting in roles, right? But also the taking on of things, the shift of identities between the two people. But also that I think that the wife here wants to acknowledge that she needs him to try. And the more that he continues not to try, the more that he just says, no, I'm frustrated and afraid of all this. There is sort of a lack of acceptance there. And I think for her, she can't force him to do what he needs to do. And that primarily is one of the things that we really like to push with people with Parkinson's, is to remain as independent as possible for as long as possible. And it really helps in general, the relationship between two people when both are moving in the same direction. So what are some of the communication challenges that we face when we're talking about Parkinson's? So we know that Parkinson's does impact communication, in particular the voice. So softness, a hoarseness quality to the voice can be noticed. There also can be mumbled speech. And primarily the loss of facial expression, so the masking of the face as it's referred to. And the reason for some of this is that there is a rigidity and a slowness in the muscles of the face as well as the muscles in the body, and that it cannot give those little micro expressions that we expect to see in people's face. It can be sort of a blankness to the face. And the problem with that, when you are communicating with someone, is it can make it look as though the person is not paying attention, or maybe the person is not taking in the information, when in fact they are. They just don't have the facial expressions that give us those cues. There also can be trouble swallowing. There can be choking. There can be coughing, things like that, that just make it difficult when you're trying to express yourself. There also can be this issue of the difficulty in finding words, so the tip of the tongue phenomenon, as it's known. And this is something that we all face as we get older, but it seems primarily to really affect people with Parkinson's, especially when they are trying to communicate. And these changes, can cause misunderstandings between two people. There also is the problem that, if someone is mumbling, if someone is not speaking clearly, then the other person is going to ask them to repeat themselves, and they may have to repeat themselves several times. That sort of frustration that builds up between two people who are trying to have a conversation, and one person keeps asking the other person to repeat themselves, it starts to feel as though maybe the person isn't listening, and the person with Parkinson's may be feeling that they are communicating very clearly, but maybe is not being heard. And so there also can be issues related to the perception of attractiveness. So if a person feels like they are constantly having to repeat themselves, that they aren't speaking clearly, that really can affect their sort of self-esteem and their self-worth and how they see themselves as a communicator. So what are some of the things that can be done to address these communication challenges? For the person with Parkinson's, vocal hygiene is very important. So one of the first things I think that should be done is to speak with the neurologist and see if a referral can be made to a speech pathologist. The LSVT program, so the Lee Silverman Vocal Technique, is a very, very good program related to improving the vocal hygiene of people with Parkinson's. It's actually been proven to be very effective and long-lasting. The LSVT program is a very intensive program. It is 4 days a week for 4 weeks. And at the end of it, the person is given exercises to do at home, very much like one would do with a physical therapist and have exercises to do at home. There also are speech therapist exercises the person's expected to continue. And if the continuation of those things is done, there can actually see a real improvement for a year to 2 years post program, which is a really great longevity in those treatments. There also are vocal exercises that can be done. So singing, facial exercises, so stretching the muscles of the face, making them more expressive. Singing in particular, I think, has been proven to be very, very good at teaching people to speak from their diaphragm, speaking them to enunciate, teaching them to put their voice out in a way that can be heard very clearly. And also that intellectual stimulation. So it's important to keep your brain active. And that's through socialization, but that's also through things like crossword puzzles and brain teasers, reading, joining book clubs, things like that. For the person who is the care partner, it's important to make sure that you are facing the person with Parkinson's when talking, to make sure that you are getting all the information that you can, decreasing background noise. So all of us, as we get older, our hearing starts to become a little more limited, and it can be harder to distinguish the noise that's coming from the person you're communicating with from the noise that is around you. And again, not relying on the facial expressions necessarily to determine if the patient is actually understanding or reacting. And being patient and allowing the person the space and the time to find the words and adjust their speech and communicate. We really, really don't want people to be finishing sentences for a person with Parkinson's, but allowing the person with Parkinson's to actually finish the sentence themselves, complete the thought. So here we're going to go back to the journals, and we see that Jane is talking about some of the issues that she's having with communication with her husband. And one of the things that we see is that sometimes you can ask questions because you already know the answer, but you just want confirmation from the other person. But that isn't really a great way of communicating. So Jane says, we both look for hidden meanings in what the other says and does. He will ask, what do you want me to do? And when I say, I think you should go to bed and lie down, he'll argue or he'll try to find an ulterior motive. Then why did he ask my opinion? So I think this really highlights that, you have to have communication in a way that is both open to actually accepting what the other person is saying, and also that you're asking some of the right questions because you actually want help and not necessarily because you just want to hear what you think you should be doing. So what are some of the nonverbal communication ways that Parkinson's is going to affect? So there are limited and rigid gestures that can occur due to the stiffness and the slowness. Again, let's talk a little bit more about masking with the facial expressions. So we had talked about how you're really missing those micro expressions and those nonverbal cues. I think it's important to acknowledge that we get a lot of information when we are communicating with somebody from things other than the words that they are saying. So we look for things like the eyebrow raising, we look for the mouth turning up a little. There's all these little things that show us that the person we're communicating with is actually engaged in the conversation. As we said, the problem with Parkinson's is that all of these sort of gestures get muted due to the stiffness and the slowness in the muscles of the face. There might also be issues related to eye contact. If a person is slightly bent over, they might not be able to keep continuous eye contact, which is another way that we sort of tell people that we are engaged in the conversation. So what Parkinson's does is it really limits all of the positive nonverbal communications rather than the negative or the neutral things that we get when we are communicating. And the biggest issue is that people with Parkinson's are often not aware that these sorts of things are happening. So what might happen then is there will be a real buildup of frustration on the part of the spouse and the caregiver because they think that the person is doing this on purpose, that they are, not engaged, that they somehow, feel that this conversation may not be worth their attention, when in fact they very much are. But there's all this nonverbal communication static that's coming in between, and they aren't aware that they actually are communicating all of these sort of negative aspects to the person. So it's important really to make sure to remember that on the part of the spouse, the caregiver, but also just make sure that the communication, that the ideas that are coming across are very clear. So what are some of the emotional and psychological challenges related to Parkinson's? So we know that anxiety and depression impact relationships and intimacy, and we also know that anxiety and depression are very common in people with Parkinson's. So people with Parkinson's are definitely at an increased risk for developing anxiety and depression, but caregivers of people with Parkinson's are also at an increased risk for poor emotional health, and that includes anxiety and depression as well as some other things. Some of the problems that we can see when we're looking at relationships is that depression and anxiety can really result in a withdrawal of intimacy or a withdrawal of mutuality. They can also have an added conflict. There can be, again, feelings of changes in attraction, both how people feel about themselves or how they might feel that a spouse feels about them. And there also can just be the very real problems of fatigue and excessive sleepiness. which can come about especially with depression. But fatigue also is its own problem in Parkinson's, that it can be unrelated to depression, but in some people is actually the primary problem that they express is this general feeling of apathy, not being able to get up and motivate oneself. So we're all going to play armchair neurologists for a moment. So this is a catalog of the daily routine of John Doe that I put together as in reading all of these journals. So we're going to read through, and then I'd like you to just take a moment to highlight some of the problems that you see as far as his daily routine, things that he should be doing, things that he should not be doing, and then we're going to discuss them, okay? So John begins by waking his wife up at 6 in the morning, and he demands help getting dressed. He may or may not eat breakfast. He falls asleep at the dining table. She wakes him up at 7:45 and tells him to lie down. He is obstinate and he sleeps at the table, or he moves to a living room chair or a downstairs bedroom, and he sleeps until 11 a.m. He wakes intermittently between 11 and 1. She comes home, they eat lunch, watches TV, or he works on his stamp collections. He falls asleep by 3 o'clock, wakes again by 6, has dinner, falls back asleep until 11:30 at night, then goes to bed with Jane, but is up and down frequently, from 1 to 6 with frequent bathroom visits, and either sits in his office desk or in front of the TV and possibly has short stints of sleep. He then wakes again at 6 in the morning and demands help getting dressed. So just take 10 seconds and say one thing maybe to the person that you're watching this with that you notice would be a problem. Great. So here's what we see. First and foremost is he demands help getting dressed without even trying for himself. What we said in the beginning is that we really encourage people with Parkinson's to be as independent as possible for as long as possible and only ask for help if they absolutely need it. Here, he's waking up and demanding help getting dressed without even trying to do anything for himself. We then see that he is sleeping pretty much through the day. He wakes for meals, but he's also sleeping in awkward places. He's falling asleep at the dining table. He is falling asleep in chairs. He is moving around the house and just sleeping. We also see that he's sleeping in front of the TV if he can't sleep at night. So he's maybe up and down throughout the night and is going to the TV several times during the day, but also at night. He then wakes up again and demands help getting dressed. So the questions are, where is the independence, which we've already talked about? But also, where is the exercise? Nowhere in here does it say that he leaves the house. Nowhere in here does it say that he walks around the block or that he goes into the backyard and does gardening or walks around the block a couple of times. So he isn't getting out at all, which is absolutely crucial. Every person with Parkinson's, as well as caregivers, should be getting about 30 minutes of exercise a day. And it doesn't have to be CrossFit. It can just be going for a walk. It's good to be outside. It's good to have fresh air. It's good to have sunshine. All of things really, really do help. As well, there is no social activity. So the only interaction he really has is with Jane in the morning and then at mealtimes. So he doesn't get any sort of socialization. And we really, when we talk about activity in people with Parkinson's, we need to have physical activity, but we also need to have social activity. It is really important to the brain's health to keep people active and interacting with one another. And we see that if people start to withdraw, if they start to not have those sort of social interactions, that they are going to do worse. What I wanted to also highlight is that at nighttime, he is getting up at night and then sitting in front of the TV if he can't sleep. So we want to highlight that screens in particular, any type of screen is really, really not the way you want to go if you can't sleep. There is a light that emanates from all of these screens of the iPads and iPhones and TV that actually tells your brain to wake up rather than to go to sleep. So if you find that you can't sleep at night, the best thing to do is to get out of the bed, to go sit in a low lit area in a chair and read some sort of print material like a magazine or a newspaper. Nothing that's too exciting. You don't want to get right back into the exciting novel that you're reading, but something that is sort of very, surface and dry. Read for about 15 minutes and then try and go back to sleep. But never turn on the TV, never turn on the phone. All of those sorts of lights are actually going to wake your brain up rather than tell it to go to sleep. So hopefully most people know the signs of depression, but I wanted to just make sure to highlight some of these things. So we see that there are things like the hopelessness and the irritability that can come about. The loss of interest and pleasure, and that really is an important thing to remember, as well as the fatigue. Now, this is difficult because we know that in Parkinson's, people can feel fatigue that's actually separate from depression. I would also speak to what we talked about in the last slide, and I will go back. It's pretty clear that John probably is depressed as well, given his routine, given his lack of interest in things, given the excessive sleep that he is showing here. So how do we address some of these emotional challenges? So depression can be a result, as we said, of the disease pathology. It can be a result of the adjustment or other factors. There are things that can be given, and the first thing to do is to speak with your neurologist if you or your caregiver is starting to feel like depression is something to take over, because there are several medications that can be helpful. So depression in caregiving, this can also just be a result of the increased stress and all the issues that we've talked about a shift, in the dynamics of the relationship. But also, I think it's really important to underline that caregivers need to pay attention to their own health, and that they need to make sure that they are not skipping doctor's appointments, that they are not ignoring their body, that they are taking care of their body and all the things that need to be addressed. Because if a caregiver is not able to take care of themselves, there's no way that they're going to be able to help anyone else. So there really needs to be, something that is done, on a very good basis. It's something that needs to be done regularly. It's something that needs to be done proactively, so that you aren't dealing with problems once they become large problems, but really starting to head them off before they get to be an issue. So here's some of the things that Jane has highlighted, and I will just give a few examples here of some of the frustration that she felt, and these journals really become a source for her to express a lot of the issues that she's having as a day-to-day caregiver. So John resents my health and his dependence on me. So we spoke about this already, but I think it's really important to repeat that there can be a real frustration that can develop between two people with regards to a chronic illness like Parkinson's, where people will say, well, why is this happening to me? And you're so healthy, and also a real frustration with oneself that one has to be more dependent on someone else. Along with that, she would say, yesterday he was feeling very sorry for himself. He feels invisible to other people who only see his illness. He must feel so helpless and furious. I have got to be aware of this. So I think this really speaks to the first point that I made, where, we want to incorporate Parkinson's disease as a part of a person's life, but it shouldn't become all of who they are. And it's really, really important to acknowledge that there is a person with all sorts of interests and feelings behind this disease, and that we really want to incorporate that Parkinson's disease is a part of the person's life, but it doesn't encapsulate every aspect of their personality and their being. He gave me a lecture, told me I overreact, don't listen, don't pay attention, assume too much, and then an apology in the midst of all the emotional pickings and prodding. No way. So I think this really does highlight, what a good communication looks like and what a maybe not helpful communication looks like. So I think it's really important to not be aggressive if there is an issue between two people, not to start out pointing out all the faults of the other person and why it is that maybe, there is no real right answer between two people. Because if you are pointing the finger and saying you overreact and you never listen and you never pay attention, there isn't really a healthy way forward between two people to solve the issue and to have a healthy line of communication. I came downstairs to lock up, do the pills, have a little cry, and upstairs to bed at 11:15. So I think this is really good at acknowledging the sort of roller coaster of emotions that can occur on a daily basis, especially for a caregiver. And that you see that she is doing all of these things. She is, making sure that that the patient's pills are all organized, making sure that the house has been secured. And then there's sort of this emotional break, and she, allows herself to cry a little bit, and then she goes to bed as normal. So I think it's important because this acknowledges the very real emotional, take that this can have on people, especially caregivers, but also people with Parkinson's who might also have a whole range and roller coaster of emotions like this on a daily basis as well. And I think it's important to acknowledge that that's okay, that this is very normal, but that it's important to keep moving forward and trying to strive to have, the best quality of life possible. So what are some of the strategies that we can look for when dealing with caregiver stress? So first and foremost, I think it's really important to be able to accept help, and not just be able to accept help, but be prepared with the ways that others can help you. I think it really helps when you have a list that says, these are the things that I am just not able to do right now. And if you could do one of these things, it would really help a lot. Being able to focus on what it is that you are able to provide, and really believe that you are doing the best you can, and be able to tell yourself that, and that you are making the best decisions that can be done at any given time. Being able to set realistic goals, I think so. Breaking large tasks into small tasks and being able to prioritize and make sure that you aren't trying to deal with the minutia, but really tackling the big things and being able to let some of the smaller things set aside. Part of what really helps with that is being able to establish a daily routine, because then that can edit out some of the sort of background noise that, that allows us to then focus on the things that need to be focused on. And also being okay with the fact that you can say no to requests, that you just don't have time for, that you don't have the energy for. Being able to be connected. And I think obviously being a part of a symposium like this is a really great start. But also finding out about other caregiving resources that might exist in the community. The Parkinson's Foundation has a great Parkinson's library, digital library, as well as resources and connections. You can also contact the local Parkinson's Foundation Center of Excellence and find out what resources they might know about in the community if you are having specific questions about something. Joining a support group as well can be very important. So the great thing about support groups, in particular when we're talking about caregivers, is that you're able to share with people who know exactly what it is that you're dealing with, but also might have some real helpful real-world solutions to some of the issues that you might be dealing with. So being able to sit in a group and talk with people and say, my husband is having problems with X, Y, and Z, and someone being able to say, oh, well, my wife had that same thing come up a few years ago, and we did this, and that actually helped quite a bit. And being able to have those sort of real world solutions, as well as a source of support for people, I think can be really great. So again, social support, making sure that you are well connected with family and friends that have ways of providing support to you, that don't make it difficult or more taxing to be in the relationship, people that you can actually connect with, and also people that you can lean on when you need to. Again, making sure that you are setting personal health goals, as well as making sure that you are active, that you're maintaining a healthy diet, establishing a good sleep routine. So sleep in particular is really, really important, both for the caregiver as well as the patient. Many caregivers do have issues with sleeping if the person with Parkinson's has issues with sleeping. And these sorts of things, obviously, as we know, if you're not getting a good night's sleep, you're feeling really, really stretched thin. And again, not ignoring your own health concerns, but making sure that you're having regular checkups with your own physician. So we will shift gears now and start to talk a bit about building and rebuilding intimacy. So what are some of the issues that might affect intimacy? New stressors related to the Parkinson's disease might stress the relationship. The dynamics, as we've talked about before, may impact the intimacy as well as the identity and the dependency that might affect the self-image of. First, we'll highlight what 4 types of intimacy exist. So we see couple time, which is quality time doing things that both parties enjoy. There is personal time. So having time to oneself is actually very important. It is not good to isolate, but it is important to have times of separation where you are doing the things that really bring you a lot of joy and that sort of fill you out as a person, and it is not necessary to be together 24 hours a day, 7 days a week. But that those sorts of timeouts where you are doing the things that really, really, speak to you and make you more of a person can really be helpful then when you come together and you're able to share those sorts of things with the other person. But also it just makes you feel as though you are doing more things for yourself and that it isn't all give, 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 and take, take, take. So then there is intimate time. So this is emotionally as well as physically, being able to sit and share thoughts, feelings, having that physical closeness, but not, without the pressure to move on to something that might be more of in a sexual realm. But being able to be intimate with a person as far as just a physical closeness. And we'll discuss some of those ways in just a second, as well as then just moving on to sexual intimacy. So obviously with the purpose of sexual arousal and satisfaction. So spending time together, it's really important to carve out a little bit of time in each day to spend with each other. Obviously, as we have seen in the last year with COVID, I think that we've all spent more time together than really we ever thought that we would. And I think this has been a really great challenge for people to be able to have that time, where we are not really able to go out and do all the things separate. And so I think it's forced people to be creative about the ways that they spend time together. And I think the important thing to understand is that it doesn't have to be extravagant. It doesn't have to be this big planned affair, but it can just be finding common ground in things that you both enjoy that also stimulate your personalities and stimulate your conversation. So things as easy as finding a TV series that both of you really enjoy, and maybe not just binge watching it, but watching an episode and then discussing it afterwards. Maybe watching an episode and then moving on and sharing a meal together or making a meal together in which you then sit and talk about the show that you've just watched, or, maybe highlight some of the ways that you think that the direction of the series might be taking. As I said, going for walks together is really important. Exercise and activity outside in particular is really beneficial. And well as being able to read and be close to one another, but also be engaged in your own task, so just sitting together on a couch and both of you reading really can create a nice feeling of intimacy between two people without that sort of pressure of needing to communicate constantly. As well as being able to plan little day trips and weekend getaways, which hopefully as COVID it becomes in something that hopefully is in our rearview mirror, that we can do more and more of these sorts of getaways. So being able to communicate, and obviously this is something that I've talked about a number of times, but being able to share things about yourself, being able to talk, being able to laugh with one another. And I think that, it doesn't all have to be important, heavy conversations, but being able to be silly with one another really, I think, is very important. But also giving each other room to table issues that maybe you're not comfortable discussing right away, that maybe you need to figure out how you feel about something before you really can have a conversation about it. And having a way to tell the person that you're communicating with, I just don't know that I can talk about this right now, but I'd really like to make sure that we find a time to talk about it. Because I think that, there are issues that come up that can bring up some very heavy emotions. And sometimes if those don't have enough space to really, be able to be developed, that they can come out in ways that are damaging to the communication between two people. Again, making sure that you're turning towards one another rather than away. And that is both physically as well as emotionally, and making sure that you really, show to the person that you are vested in the communication that you're having. Being able to rely on one another for that communication, and showing the empathy and compassion for the other person, that you really do care about what it is that they are saying and why they are saying it. As well as being able to express your appreciation for one another and your needs. I think that it's really important to make sure that this is not a guessing game between two people, but that you clearly communicate what it is that you would like to get from the other person in a way that isn't accusatory, but is a way of sharing, these are the things that are important to me. and making sure that you are telling your partner what it is that you would like to do that might be a way of bringing the two of you closer. So just a moment to talk about the power of touch, because I think this is something that really is very helpful in building intimacy or rebuilding intimacy, but it's the simple things. And this isn't sexual touch. This is just holding hands. This is being able to hug. This is being able to be close to one another. There are all sorts of ways that one can have that sort of physical intimacy. But first and foremost is that it really does build a very strong sense of safety and comfort between two people when you are just in close proximity to one another. And being able, as I said, to do things like maybe sit on a couch together and read. Being able to do things like, give each other foot massages, being able to wash one another's hair. These are all things that really build a sense of intimacy between two people. Another thing is to make sure that you are being positive and invested. And I think that the easiest way to do this is to always try to lean positive rather than negative. Try to keep the positive attributes on the forefront of your mind. I think too often we can get caught up in the frustrations of daily living, the frustrations that we might be having with the person, the frustrations that we might be having with ourselves, but being able to say, that those are frustrations that exist, but also remind yourselves why it is that you love one another, why it is that you've chosen to be with one another. I think a really easy way to do that is to try and express a vested interest in the hobbies of the other person. And we talked a bit about the importance of being able to have alone time in which to pursue those hobbies, but also making sure that you are sharing those sorts of things with one another. Being able to maybe share your favorite poem or your favorite book to the other person. And what I think this really helps is that it expresses your interest and it gives your partner also an opportunity to know another side of you. So what are some of the things that you can do as sort of ways to share and to get more information? So one thing is to reminisce about your first date. I think that it's really important to talk about these sorts of things because it's amazing how two people can have vastly different impressions of the same experience. And I think that what's really nice about that is you can learn and you can find out more about something that you were actually involved with, but that you maybe didn't realize had happened. Another way to do that is to talk about maybe vacations that you have taken. And that maybe highlighting what was the best part of the vacation and what was the most challenging part of the vacation. And seeing how if they match up between the two people or if there is something vastly different between the two people. Being able to play games like 20 questions. So we are constantly needing to gather new information. And it's amazing that you can be married to someone for 30 years and still be learning new things about one another. But that's also an important part of rebuilding an intimacy and relationship between two people is that you both are showing that you are vested in learning more about the other person, but also that all of that new information can actually lead in new directions as far as your relationship is concerned. Another thing, we live now in the time of the internet where pretty much every song you can ever think of, if you Googled it, would come up and you'd be able to play it. So taking turns, maybe just sitting with a laptop and playing a series of songs that were important to you in times of your life, and maybe telling a story that goes along with the song to the other person and taking turns doing that. I think is a really great way of maybe learning about new things from a person's past. You might also turn it into a game and see if the person can guess who the singer was, who the band was. But also you can then pick out songs that maybe were important as part of your relationship, part of your past, as a way of also reminiscing. And maybe another thing that I really like actually is both of you identifying a book that you've always wanted to read and being able to maybe read the book together and discuss maybe things about it. And so, maybe you take turns reading the book that one person wants and then the other person. Maybe you trade the books and you each read the book of the other person first, and then you trade and you read the book that was important that you've always wanted to read. And it can stimulate a lot of really great discussions. And again, how different two people can actually perceive the same thing. What are some other easy ways? Maybe planning a weekly game night or a date night. Having nightly check-ins before bed. So I think there's an old adage about never going to bed angry. And I think this is really important. It's not necessary that you hash out every problem of the day before you go to bed, but it is important to at least check in and acknowledge that both of you are in a place that you feel like you've been heard, and also that you want to make sure to revisit if there is something that needs to be revisited. Being able to spend time together without electronics and just focusing on your partner. Again, this is really important in building intimacy between two people and not having that sort of electronic divide between you. So sitting on the couch, both of you looking at your smartphones, in some ways just isn't the same thing as sitting on a couch reading together. That it's very organic to be able to read and discuss. Whereas I think that electronics and phones and iPads and all those sorts of things really put in a sort of digital divide between two people. Being able to start new projects together. So I think, again, this last year has taught us that there's all sorts of things that we can find to do within our house, especially when we've been sheltered. So being able to take up new things like baking, maybe puzzling, restoring pieces of furniture. And I think also, the fun things, the things that maybe we don't think about on a day-to-day basis, like writing love letters to one another, or, writing a daily poem together that expresses some sort of silly thought, some sort of fun thing that you share. But being really creative and that it doesn't have to be Shakespeare, it just has to be something that both of you enjoy. So what are some other ways that we have to build or rebuild intimacy? Again, I think it's really important to just be okay with being playful, that it really makes communication a lot easier, that humor can really help to lighten moods, especially if you're talking about heavy things, but that it has a way of just breaking the tension that maybe can start to exist between two people. And along with that is being honest. So being able to trust and relax, and that can be very attractive to people when you are being honest, when you are really telling what it is that you feel and what it is that you are hoping for. Being able to discuss new ideas, try something new, being able to discuss it openly with your partner, and being able to be open to their ideas as well. So having more time and fewer distractions can really stimulate a lot more creativity between two people. And being able to talk openly about your needs and desires, as well as your concerns, as you sort of rebuild that intimacy. So we'll speak for just a moment about sexual intimacy and sexual relationships. So there was a survey done of patients evaluating the effect of Parkinson's on sexuality, and that most people reported that there were decreases in the frequency of intercourse, the sexual arousal, and sexual satisfaction. Overall, men seem to show deteriorations in sexual domains such as not being able to reach orgasm, being fearful that they are not fulfilling the sexual expectations of their partner, and just this general dissatisfaction with sexuality in the relationship in general. So we do know that Parkinson's motor symptoms can impact the sexual function of people. So there are changes in the physical ability to be able to perform with regards to the slowness and the stiffness of muscles. Changes in how one is able to touch and be touched, maybe that there's some limited dexterity, as well as just maybe changes, as we have talked about before, in the perceived desirability or the attractiveness that a person might feel. There are also some non-motor symptoms that do impact sexual function. So constipation can obviously make things very uncomfortable, as well as bladder dysfunction. Hypotension can result in maybe performance changes with regards to erections. Sleep disturbances can maybe add tension to a relationship if the sleep disturbances are bad enough that can actually force two people to sleep in separate beds, which just sort of creates a divide, a physical divide between two people that can just decrease maybe some of the issues with intimacy. We've talked about how depression and anxiety can, as well as maybe the shifting role changes, can just change the feeling of self-image that one might have, the confidence that one might have, and can lead to maybe some decreased desire, as well as just the fatigue that we've talked about, which again can really just make people not feel up for much, and can really decrease the desire that people have, as well as maybe just being able to be aroused. So there also is an issue related to some of the medications that people take with Parkinson's. So I'm not a physician. I can't talk too much about medication, But I can say that there are things that, medications that can result in a hypersexuality or a compulsive sexual behaviors. Anything like this should definitely be discussed immediately with your neurologist. And that's important to remember that people with dementia may also exhibit maybe some abnormal sexual behavior. So how do you adjust? How do you adapt to changes in sexual function? First and foremost is to make sure you're talking with the doctor about this, that referrals can be made to urologists or gynecologists as needed if there are other issues that need to be addressed. Being able to be flexible and shifting from what they call goal-oriented intercourse, where the goal might be an orgasm, to more pleasure-oriented outer course. So this is everything that isn't intercourse, but that can be pleasurable to one another. And again, it's allowing that flexibility. It's allowing that that ability to just be involved in a sexual relationship and in a sexual way without having to be oriented towards the goal of this is sexual intercourse. And it's also, important to highlight that counseling is available, that there are things like couples therapy as well as sex counselors that can be made available to help people who might have a difficulty having, these hard talks, maybe these communications with one another. But important, to remember is really all of these come down to, that intimacy is about tenderness. It's about contact. It's about building a relationship. And the ways that you take the pressure off that is really that you're able to take your time, that you don't necessarily have all the pressures that you might have had 20 years earlier. Being able to have far more time to devote to working and having these intimate relationships. And that it isn't necessarily something that always has to happen at the same time every day or the same time every week, but is something that can be stretched out, over a series of hours, over a series of days. And that, it's really that it's up to you. It's up to you to be as creative as you want, to create as big of an experience as you want. And, that, again, allowing yourself to be silly with it if you want to, write a funny erotic limerick or find a poem that is erotic or romantic, but really to be able to create an experience. And again, not being shy about physical contact, being able to hold and touch your partner, being able to communicate how it is that you want to be held, how it is that you want to be touched, and sharing maybe new experiences that you might have together. And most importantly, being able to relax, that really does take the pressure off between two people, and remembering that this is supposed to be fun. This is supposed to be enjoyable. This isn't something that, you're going to be graded on, but more so, this is something that should, foster confidence, should be able to provide comfort, and should be able to provide satisfaction, and being able to highlight and communicate what exactly it is that you would like that's going to give you more pleasure and give you more relaxation. Again, the goal of intimacy is a mutual enjoyment and pleasure. So being able to focus on comfort, being able to focus on relaxation and pleasure rather than ultimate performance. Being able to be sensitive and not have, and eschew those expectations that a man should do this or a woman should do this, and being able to let go of all the thoughts that might be stirring around and really come back to the body and what it is that feels good, what it is that makes you feel good, and asking what it is that I am a yes to. And lastly, I think just being able to, again, expand the definition of sex so that sexuality really can take on this broader definition, and that it isn't necessarily just about the act of intercourse, but that it is all those things about emotional pleasure and sensory pleasure, relationship, that intercourse is only one way of having sex, but that touching and kissing and all these other things can be just as rewarding. And as well as acknowledging that there are natural changes that as we all age, and it's normal that you might find that you have different abilities, different needs, but being able to be open and communicate about all those things will ultimately, I think, lead you to have more pleasurable experiences and also bring you closer together. So I want to take a moment to just thank Sheila Silver and Gila Bronner, who have both given a lot of talks with regards to intimacy and sexuality and Parkinson's disease. As well as John and Jane Doe, who were the subjects of the journals that I shared with you. And I also want to just say thank you so much for allowing me to speak with you today. I hope it's been very helpful, and I hope that you have an enjoyable rest of your day. Thank you so much. Stay safe, stay healthy, take care.